All right, so first of all, thank you to the conference organizers for giving me this opportunity to present my work today. As was said, my name is Evan Cunningham, and I'm presenting on behalf of my colleagues, reinfection following successful DA therapy among people with recent injecting drug use. So I have nothing to disclose. So as we've heard throughout the day, there's a significant burden of hepatitis C infection among people who inject drugs globally. And we know that treatment is safe and effective in this population. So the Simplify and Defeat studies, where I'm drawing the data from for this analysis, demonstrated 94% and 91% efficacy, respectively. We know that reinfection following therapy has been one of the major concerns regarding the scale-up of treatment in this population. And this is largely because there's limited data, especially in the DA era, of reinfection following hepatitis C DA therapy, particularly among people with ongoing injecting risk behaviors. And so the aims of this study were, first of all, to assess the incidence of hepatitis C infection, and including stratification by key variables, and investigate the predictors of time to hepatitis C reinfection. Okay, so just a little bit about these studies before I get into the results. So Simplify and Defeat were both investigator-initiated, open-label clinical trials. They recruited in 25 different sites across 8 different countries. And so those two maps at the bottom there just sort of highlight where those sites were. So the recruitment was done through the same recruitment network. So there's actually some overlap between those studies, but there are some unique sites as well for each. And recruitment was done through a network of drug and alcohol clinics, hospital clinics, and community clinics. And participants were enrolled between April 2016 and February of 2017. So to be included in the study, participants needed to be DAA treatment naive with genotypes 1 through 6, and they could have any fibrosis stage. In Simplify, participants were treated with sofosbuvir and valpattosvir, and in Defeat, participants were treated with the 3D regimen. And so there was a slight difference in the recruitment strategy or the inclusion criteria for the two studies. So in Simplify, participants needed to have reported any injecting drug use in the last 6 months, whereas in Defeat, they could have either reported any injecting drug use in the last 6 months or currently be receiving OAT. And participants with, or patients with HIV and decompensated liver disease were excluded from both studies. So reinfection was measured every 6 months following SVR24 in this study. And so that timeline at the bottom there just sort of outlines what the study schedule, or the visit schedule was. So visits were done at ETR, SVR12, SVR24, and then every 6 months thereafter, so week 60, 84, and 108. And at each of these visits, participants were tested for HCV RNA and completed a follow-up questionnaire for self-reported risk behavior. And we assessed reinfection from the end of treatment and distinguished reinfection from relapse using viral sequencing of the core E2 region. So obviously in this study, reinfection is our primary study outcome. And this was defined as quantifiable HCV RNA following DAA therapy. And obviously this could be confused with relapse, which is why we used viral sequencing to distinguish these two. We calculated the rate of reinfection using person time of observation, and we report it as the number of cases of reinfection per 100 person years. And finally, we assessed factors associated with time to HCV reinfection using Cox proportional hazard models. All right, so just a little bit about the study population before I get into the reinfection data. So 177 people were eligible for inclusion in this study. The majority were male, so around 73% were male. A slightly older population with a median age of 48 years. 62% were currently on OAT at the end of treatment. And then just a little bit about their injecting following the end of treatment. This is any time after completing treatment. So 73% reported any injecting drug use in this period. 36% reported greater than or equal to daily injecting at least once in this post-treatment period. And only 6% of the population reported any needle and syringe sharing in this period. And the primary drugs injected following treatment were heroin, methamphetamine, other opioids, and cocaine. So overall, there were a total of 11 cases of viral recurrence, and through sequencing, we determined that 8 of these were due to reinfection, and 3 were relapse. So this table here just sort of gives some more in-depth detail on these 8 reinfection cases. So you can see that 75% of the reinfections occurred among men, and so this is quite in line with this distribution of male and female in the study. Age was somewhat younger, so only 2 of the age there who had reinfection were older than the median study age of 48 years. Reinfection occurred in a number of different countries, so it occurred in Canada, Australia, New Zealand, and Switzerland. In regards to injecting drug use, we see that 7 out of the 8 participants reported any injecting drug use post-treatment. And this is probably a good chance to point out one of the limitations with our survey, is that we asked for risk behaviors in the past month. And obviously, since we weren't following them up every month, that doesn't necessarily incorporate all time at risk. So there is a chance that risk behavior did occur that wasn't captured by these surveys. And so the highest frequency reported was greater than or equal to daily in 6 out of the 7 cases of reported injecting. And the main drug was varied. Morphine, heroin, methamphetamine, and cocaine were all reported as the main drug injected. 4 out of the 7 individuals who reported injecting reported sharing a needle and syringe. And reinfection was detected at or before week 60 in 75% of the cases. So overall, the rate of reinfection that we observed in this study was 3.1 cases per 100 person years. And this was over a total of 254 person years of follow-up. And this just Kaplan-Meier curve just sort of demonstrates the proportion of people who remained hepatitis C negative over time. So I won't make you squint too hard to see all the numbers on this figure. The first thing I want to point out is just that we have very wide confidence intervals, and this is largely because we had so few reinfections. So as a result, each group doesn't have that much power, and so you have a lot of overlapping confidence intervals here. But there are a few that I just want to highlight. And in the majority of these cases, 3 out of the 4 cases, we do have overlapping confidence intervals, so I just want to make that clear. But those are that there seems to be an elevated rate of reinfection among people who are younger, people who are not on OAT, people with daily or greater injecting, and people with needle and syringe sharing. So people with needle and syringe sharing, there is a division between the confidence intervals for those ones. So we also then went on to do Cox proportional hazard models. And so first we did one among the entire study population, looking at some demographic factors as well as injecting. And the 2 I want to highlight here are first age. So the only one that came out as significant in this analysis was age. So people who were younger had a shorter time to hepatitis C reinfection. But I also wanted to point out opioid substitution therapy. So you'll see in the confidence interval there that it does cross 1, so it isn't quite significant. But it does look like there might be some protective effect of opioid substitution therapy on reinfection. And next we did a second unadjusted model among people who reported any injecting in that post-treatment period. And the one I want to highlight here is, again, syringe sharing. So we see that people who shared needles and syringes and injected had a significantly shorter time to hepatitis C reinfection compared to those who did not. All right, so just to sum things up, so essentially, reinfection following hepatitis C therapy does occur. We know this, and we've seen it in a number of different settings and studies, so this is really just confirming that. We see an elevated incidence of reinfection in those who are younger, those who are not on OAT, those who injected daily or more at least once, and those who reported needle and syringe sharing following treatment. When we then did the Cox models, only 2 of these actually came out as significant. So that was younger age and needle and syringe sharing being associated with shorter time to hepatitis C reinfection. And unfortunately, we couldn't do adjusted Cox models, and that's again largely because we had so few reinfection events. The incidence of reinfection is consistent with previously reported rates in the interferon era, so that's quite encouraging, and it seems to be a relatively modest rate in compared to some of the rates we've seen of primary infection in different settings. But unfortunately, we don't have the rate of primary infection for this specific study population to directly compare the 2. And finally, just DAA treatment has the potential to be, I think, has the potential to be used as an opportunity to encourage safe injection practices and the uptake of harm reduction. And I think, while it'd be nice if we weren't getting any reinfections, and high coverage harm reduction, such as needle and syringe programs and opioid substitution therapy would go a long way to achieving this. What it means is that we're treating the right population. This is a population that is not only at risk of becoming reinfected, but also at risk of potentially transmitting the virus. And so if we want to continue to address elimination targets, and including the reduction of the incidence of hepatitis C, it's important that we see reinfection in this light and we provide timely retreatment for those who become reinfected, rather than using reinfection as a way to further stigmatize an already highly stigmatized population. And so with that, I'd just like to thank all the Simplify and Defeat study participants, all the study coordination staff, and then too many people to name in both the Simplify and Defeat study groups, but just thank you to everyone who's on this slide. And I'm happy to take any questions.
This paper is open for questions, and we have a couple minutes for questions.
Hey, Evan. Two things. The 3 relapses, were they early relapses or post-SVR12?
They were all at or before SVR12.
Good. And in terms of the interventions, I mean, obviously, you know, introducing sort of needle exchange and having them adhere to it might have reduced the reinfection rate by half.
Yeah,
that's a neat thing to look at.
Yeah, so these were studies where harm reduction was provided as standard of care at each of the sites. So it is true that some of them may have been providing needle and syringe programs with relatively high coverage, which may not be the case at a lot of community centers.
So, hi, Zoe Greenwald, University of Toronto. Thank you so much for your presentation. It was really fantastic. I'm wondering if there's any other data on other risk factors for acquisition and reinfection after the end of treatment. Like, was there any data on sexual transmission or sharing of other drug equipment other than needles, like hookers?
No, so we did have information on sharing other injecting equipment, but there didn't seem to be any other sort of, essentially the people who were sharing needles and syringes were also sharing others, so it wasn't really able to be teased out any further than that, and we didn't have information on sexual transmission.
Yeah, thanks. Sorry, over here. Hi, I just wanted to ask whether people were reinfected with the same subtype as they had for their primary infection. I would have thought kind of immunologically they may be most at risk for an identical subtype to that which they were first infected with. And I wonder if you've been able to tease that out.
Yeah, so in a few of the cases, I think probably half the cases, it was the same genotype and subtype. This paper was recently accepted for publication in Clinical Infectious Diseases. So there is a figure in there that gives the natural history of infection, and it does report. I just can't remember off the top of my head exactly how many were the same, but there were quite a few that were the same.
Well, if there are no other questions, then I think we'll conclude this session and thank our speakers once again for excellent talks and excellent papers.